And today, our first scientific session is on adverse outcomes of blood transfusion, making the case for transfusion avoidance in modern medical practice. And our first speaker is Dr. Mark Friedman. So, Dr. Friedman is a clinical associate professor of pathology and the medical director of the transfusion service at NYU Langone Hospital, Long Island, NYU Grossman Long Island School of Medicine, and the Department of Pathology in Mineola, New York, in the USA. Dr. Friedman is an associate professor of pathology and the director of transfusion and therapeutic apheresis services at NYU Langone Health and Grossman Long Island School of Medicine in the US. He has over 25 years of experience in the field of blood banking and transfusion medicine, and he's board certified by the American Board of Pathology. He holds memberships in multiple organizations, including SABM, the AABB, and the Blood Bank Association of New York State, and he has extensively published on topics covering patient blood management, including his contributions to the PBM column for the AABB website. And his research interests include insights into appropriate blood utilization and PBM education. And I'm super excited to hear his talk this morning. So take it away.
Thank you for that wonderful introduction. Let me just share my slides here. All right, can everybody see that? Yes, okay, good.
Yes.
All right, so it's wonderful to be invited to talk at this session. And as noted, my topic here is adverse outcomes of blood transfusions and making the case for transfusion avoidance in modern medical practice. Now, so I have no disclosures for this presentation. And the learning objectives are to recognize historical transfusion risks, such as hepatitis and HIV in the current context, to explain the transition of transfusion risk reduction from transmissible diseases to non-transmissible disease risks, and to analyze the case for transfusion avoidance and transfusion risk reduction. So I put this champion athlete up, tennis player, who some of you perhaps, or maybe many of you recognize is the late great Arthur Ashe, who in fact has a tennis stadium here in New York named in his honor, where they play the US Open every year. However, what fewer people might remember about him is that he became an HIV/AIDS activist before dying from AIDS, unfortunately, in 1993. And the way he acquired HIV, of course, was through blood transfusion. So I bring him up here in memoriam, in part because our paths sort of intersected, because much later on, I actually became the blood bank director in that New York City hospital where he got that unfortunate blood transfusion. So it just serves as memory of the, that era of blood transfusions during the HIV epidemic. Stepping back a moment into post-transfusion hepatitis, the risk of post-transfusion hepatitis dropped from the 1940s with the introduction of a hepatitis B surface antigen screening in the late 1960s to early 1970s. And it was originally called the Australian antigen because it was, the agent was identified apparently in Australian Aborigines. But the post-transfusion hepatitis risk, despite hepatitis B testing, was still very high, perhaps as high as 10% in the 1960s to post-1970s. So it was still very high, and that was because of non-A, non-B hepatitis was really largely the agent that was being transmitted, and later, of course, identified and then around 1990 as hepatitis C. What the U.S. did around that time to try to make the blood supply safer, of course, was to call to action a move to voluntary non-paid blood donor supply in the U.S. And then later, after HIV, we tried to identify high-risk donors, and so we started testing liver enzymes, ALT, and also introduced hepatitis B core antibody testing. That somewhat reduced the risk of non-A, non-B post-transfusion hepatitis from about 1 in 200 to 1 in 400. And then, of course, as I mentioned, in the 1990s, we identified hepatitis C as the agent and began testing for that. Nevertheless, now if we look at the current context, there are some who want to go back to paid blood donations, particularly for platelets. And when you look at this particular paper, these authors actually were arguing against that move. Yes, we have better methods to screen and test donors. We also have newer technologies such as pathogen reduction technologies, which can inactivate these viruses. But then they were questioning whether this would erode the altruistic donor base. When it came to post-transfusion HIV, which of course was epidemic that started in the 1980s, but the first documented case of post-transfusion HIV in the US occurred in 1982. And then after we identified the agent as a retrovirus in around 1984, then we began antibody screening in 1985. And also at that time, that's when we began to defer high-risk donors. Men who had sex with other men were considered to be high risk and were basically deferred or banned from donating until most recently now when we've actually put more individual risk factors to evaluate donors. So then HIV NAT testing was added in the 2000s. In between the antibody testing and the NAT testing, and briefly in the 1990s, we were doing HIV P24 antigen testing, which started in 1996 here in the US. And that, of course, was the goal was to reduce the so-called window period, which is the period between acquisition of the infection and ability to detect the virus. So with antibody testing, that window period was about 3 months. When we went to P24 antigen, we greatly reduced that. And now with the latest in NAT testing, we have about a 10-day window period. And of course, today we test not only for HIV-1, we also test for HIV-2, and also the outlier HIV-1 group O HIV. So in today's context, post-transfusion HIV, of course, like hepatitis C, is extremely low in the order of 1 to 1.5 to 2 million. So it's extremely rare. Nevertheless, we can see that cases occurred in the US even as late as 2008. So, we still have to be cognizant of HIV in the blood. So you can see that with our current screening and testing, HIV, hepatitis B, hepatitis C, extremely rare to get that. But they should not be forgotten, in part because nowadays we have these very highly active antiretroviral medications that people take for post-exposure prophylaxis and even pre-exposure prophylaxis. And these can render even infected people negative, even on NAT tests. Though it still can be, the virus sexually cannot be transmitted for people who take these medications, but through blood, it can still be transmitted. So we really have to be cognizant of this. And today, the FDA has recommended that donors who take these medications be deferred for 3 months. But what is the cost that we how much are we willing to spend in order to make the blood supply safe? And if we look at just one agent, babesiosis, which of course is a parasite that, like malaria, infects red blood cells, but is endemic here in the US and parts of the US, particularly in the Northeast, where I'm located, and also in parts of the Midwest. So you can see, normally when we look at cost expenditures, in terms of healthcare interventions, we measure them in something called QALYs, or quality adjusted life years. And its benchmark is said that if you spend about $1 million per QALY, that's basically considered to be a worthwhile intervention. But once you exceed that expenditure, then the healthcare dollars are getting very expensive. So if we look at just testing for babesiosis, if we just screen through the donor history here at the top, you can see you're spending about $160,000 to make the blood supply safe per QALY. If we now add targeted antibody PCR, that is, if we're just doing it in endemic areas of the US, we're spending over $700,000. And now if we do universal antibody, meaning that all donors are being tested by ELISA antibody, we're spending over about $760,000. And then when we go to universal antibody and PCR testing, it gets upwards of almost $9 million. So it gets very expensive. So you can see we're spending a lot of money to make the blood supply safe. Now, if we move beyond transmitted infections, we can see that we have a number of other risks that we have to be cognizant of. ABO, hemolytic transfusion reactions, which usually occurs because of patient misidentification. The usual mechanism is that it's what we call a WIBIT, or warm blood in tube. And so what happens is the sample gets labeled with the intended recipient, but for whatever reason, the blood is collected from a different patient. And then when that sample is sent to the blood bank, they type the patient and that sample and cross-match to that sample. The blood gets transfused back to the intended recipient now, but clearly it was cross-matched to a different patient, and it can end up in a hemolytic reaction, which can be unfortunately fatal. Transfusion-associated circulatory overload, or what we call TACO, volume overload essentially, transfusion-related acute lung injury, trolley, bacterial contamination of platelets, hypersensitivity anaphylactic reactions, alloimmunization in terms of HLA antibodies, and delayed hemolytic transfusion reactions, transfusion-associated graft versus host disease in immunocompromised patients, and iron overload, transfusional hemochromatosis, and finally, more esoteric reactions such as transfusion-related immunomodulation, TRIM, and prothrombotic effects. So looking at ABO hemolytic reactions, you can see that this should be a never event. I mean, we know what the donor blood type is, and we certainly know what the patient blood type is, but somehow, as I mentioned, there is a mix-up, a clerical error, and unfortunately, it leads to these hemolytic reactions. And in this case, it was reported that a woman in Texas here in the US was given the wrong blood, and she unfortunately died of that consequence. So how do we deal with this? Well, if you look at this chart here, what many transfusion services have adopted is nowadays is we will, of course, we always do a history check, but if we don't have prior type and screen on the sample, prior history, what we do is we ask for a second sample to confirm the ABO type and make sure that it matches up and that we have the right sample from the right patient. So we've identified the patient correctly. Nevertheless, I have to say that in my experience, I've seen clinical teams that they don't really understand the purpose of this, and they think that we're just trying to make things more difficult for them. And so I've seen situations where, for example, they'll collect 2 samples at one time, put one in the pocket, then give the first sample, and when we ask for the second sample, they'll pull that second sample out. So I mean, we try to put these safety measures in place, but yes, there's always a way to bypass that. Some hospitals, what they'll do is they'll actually have special tubes for the second sample that can only come from the blood bank, so that they cannot just collect the 2 samples at one time. Sorry. All right, moving on to TACO, or transfusion-associated circulatory overload. And you can see that, the ABB put out this bulletin in 2015, and they updated it in 2023. And you can see that, unfortunately, TACO remains a leading cause of transfusion-related morbidity and mortality. And you can see that TACO contributes, may have contributed to over 21% of transfusion-related deaths. And although TACO symptoms have been recognized for more than half a century, we still incompletely understand all of the mechanisms. It seems fairly straightforward. but it's a little more complicated, as we'll see. So certainly we try to identify at-risk patients, patients who are older or female sex, patients who have underlying renal failure or pre-existing cardiac dysfunction or chronic pulmonary disease. There are also practice-specific practices that put the patients at risk. For example, giving more than 1 unit of blood. So we always say why give two when one will do in terms of red cells. So certainly if they're doubling up on their red cell transfusions, that can contribute to a TACO. Giving faster rates of transfusion. Plasma transfusions tend to be greater risk than RBCs because they are given in multiple units in order to get an appropriate dose. And so these are things that do contribute to the risk of TACO. And there are certain biomarkers that we can measure, like the BNP, for example, the brain nature ureatic peptide, as an indicator of TACO. How does TACO occur? Well, there are physical forces like the Starling forces, which, when the pressures get high, they'll push fluid from the pulmonary vasculature into the airspace. Pulmonary vasoconstriction, the blood vessels tend to tighten up, and that again can contribute to increasing pressure and fluid leaking from the pulmonary capillary vessels into the air spaces, and endothelial damage, so you get leaky vessels. But these aren't the only contributors. We do know that there is a component of inflammation involved, and we used to say that TACO really was, fever was not really a component of TACO, but today we recognize that even up to about a third of cases can, have fever. So this has been something that's been labeled as a hot TACO in the literature. Transfusion-related acute lung injury is another differential when we're looking at transfusion-related pulmonary edema. And this is more, yes, there can be an inflammatory component, as I mentioned, to TACO, but this, does always has an inflammatory component to it. And it tends to occur in very sick patients, particularly those in the ICU. And the underlying illness leads to neutrophil priming, which then attaches to the endothelium, these primed white blood cells. And then when we, in the second hit, when we infuse either HLA antibodies or these bioactive lipids that build up in stored products, that leads to the second hit and activates these primed white blood cells and leads to the leaky capillaries, pulmonary capillaries, and hence the fluid, the pulmonary edema that occurs. So here the ABB put out a bulletin back in 2014 about mitigating TRALI and preventing TRALI, trying to reduce the risk of TRALI. And one of the things that was recognized is that, one of the big drivers of HLA antibodies, that's a risk for that second hit in TRALI, is pregnancy. So if we can simply eliminate particularly plasma products from female donors, or at least get products from females who are tested for HLA antibodies, that would make the blood supply safer. So we sort of have this male, predominant plasma to try to make the blood supply safer from TRALI. However, TRALI is still incompletely understood, and you can see that it was although cases occurred prior to 1983, the term TRALI was coined by Popovsky and others in 1983. And then the definition was updated around 2004 by the Canadian Consensus Conference, which sort of put the definition as this pulmonary edema that occurs within 6 hours of transfusion that's related to, not related to other acute lung injury factors, and certainly not related to heart failure. But nevertheless, additional updates to the definition came out in 2005 and again in 2009 and 2018. And most recently in 2019, they sort of then divided TRALI into type 1, where there's no other underlying acute lung injury, or type 2 when the patient does have risk factors for ARDS or mild ARDS. But the current event is clearly not related to those underlying risk factors or pre-existing mild ARDS. And more than just the classic mechanism that we understand about the two-hit hypothesis, the priming of the white blood cells as illustrated, and the activation, nowadays we're looking at additional causes for TRALI, or mechanisms of TRALI, including macrophage secretion of osteopontin and these so-called neutrophil extracellular traps that can occur as another mechanism. So TRALI is certainly much more complicated. And as they do further investigation and come up with different mechanisms that might lead to TRALI, they're trying to come up with different ways that we can potentially either avoid or treat TRALI. Bacterial contamination in platelets, has long been problematic, simply because we store platelets at room temperature, and no matter how much we try to sterilize and clean the skin when we collect these blood products, there's always going to be some bacteria that gets into the blood product, and of course, since it's sitting at room temperature, that can promote the overgrowth of bacteria in these products. And we know that, unfortunately, bacterial contamination has been one of the more common causes of transfusion-related deaths, at least globally and in the U.S. But there still exists no standardized test to detect all bacteria in platelet units, and regardless of the method, bacterial screening of platelets is unlikely to detect all pathogens. So, we've introduced a lot of mechanisms to try to reduce the risk of bacterial contamination of platelets and consequently septic reactions. One of these mechanisms that we put in place is the so-called sample diversion pouch, which is over here. Basically, what we do, we recognize that when you put the needle into the donor arm, not only do you get the blood flowing out, but you get a big piece of skin that gets into that needle. And that skin, if it gets into the primary bag, it has a lot of a lot of bacteria that's associated with it, and that can promote overgrowth of the bacteria in the product. So what we tend to do nowadays in the donor collection sites is we actually divert a small amount of the initial collection to get rid of that skin plug, and we can use that for transmissible disease testing, for example. And then in midstream, we can switch the collection into the main bag, so we avoid that skin plug and reduce the amount of bacteria that gets into the product, and that should mitigate or at least reduce some of that bacterial overgrowth and consequently septic reactions that we see with platelets. So in 2019, and again updated in 2020, the FDA, in recognition of the risk of bacterial septic reactions, came out with this guidance to promote reducing the risk of bacterial septic reactions, bacterial contamination of platelets. And this guidance basically listed various steps that we can use in order to test platelets and make them safer from bacteria. One of the more common strategies that many blood centers here in the US use is so-called large volume delayed sampling platelets. And what they basically do is they wait 48 hours, let any bacteria grow, and then they will culture it to see if they can detect any excess bacteria before releasing that product. One of the downsides of that, though, is because they are taking larger samples from that platelet unit, we might get a little bit less platelets in the actual product. So what we call low yield platelets. But of course, when we look at the platelet requirements here for concentration or yield in the US, it's higher than in European and in Canadian nations in any case. So even if we do get a little bit lower platelet yield, we're still, we still have an acceptable product for transfusion. Another technology that we now have is so-called pathogen reduction, which the FDA has recognized as promoting safer products against bacterial contamination. And when we look at this technology, essentially what we're doing is we're adding a photoactivating chemical, a psoralen agent like amotacillin, and then what this does is it cross-links, we're then subjected to UVA light, and what this does is it cross-links DNA and RNA, and it knocks out all kinds of pathogens, bacteria, viral pathogens, including HIV, hepatitis C, hepatitis B, and even white blood cells, rendering the product safe from graft versus host disease. Transfusion-related immunomodulation. So this is a more esoteric type of risk that was first recognized in the early 1970s by Peltz and Terasaki and others. And actually, it was looked upon as a favorable consequence of transfusion. So what they would do is in their kidney transplants patients, they recognized that the patients who actually got blood transfusions and got their renal transplants, the renal allografts survived longer, because essentially what was happening is that the active white blood cells in these products, back then, of course, it wasn't, they weren't universally leukoreducing like we do nowadays. So you have lots of white blood cells in these donor products. So these white blood cells in the donor products would essentially immunosuppress or downregulate the recipient's immune system, and that would prevent allograft rejection and longer survival of the kidney allograft. So they would actually intentionally transfuse the patients who were undergoing kidney transplants. Of course, then, in the 1980s, there was the HIV epidemic, so they stopped doing this, and of course they developed better immunosuppressive agents like cyclosporine. So nowadays we recognize TRIM as a negative outcome of transfusion, and there are various mechanisms that have been promoted to explain why TRIM occurs, including not only the active white blood cells in the donor product, which we largely remove nowadays through universal leukoreduction, but also formation of extracellular vesicles and free hemoglobin and iron that occurs in these stored products. And in platelets, free CD40 ligand is another promoter of TRIM. So suffice it to say that there are multiple mechanisms that can lead to this transient immunosuppression in those who receive blood products. And we recognize that this has a negative outcome because it can lead to organ dysfunction, nosocomial infections, and even progression of malignancies. We know that, for example, in perioperative patients, it certainly does increase the risk of infections in that group of patients. Prothrombotic effects. So we see here from this study in patients who were undergoing total joint arthroplasty, and as they received more blood transfusions, their risk for venous thromboembolic events increased. So we know that transfusion of these products, they do have prothrombotic effects. So as a result of all of these risks, the World Health Organization not long ago in October 2021 put out this brief, this policy brief on the urgent need to implement patient blood management. And I know that this was a slide that was shown in an earlier presentation, but just to go over it again, the World Health Organization largely were looking at this data from the largest patient blood management program in the world, from Western Australia. And this particular study was looking at over 600,000 patients from that region. And what they found was that there was a correlation that when they reduced the risk of red cell transfusions here by over 40%, plasma by nearly 50%, and platelets by nearly 30%, They had a nearly 30% reduction in mortality, over 20% reduction in infections, over 30% reduction in thrombotic events, including acute myocardial infarctions and stroke, and the length of hospital stay decreased by 15%. And there were the key program indicators were that they reduced preoperative anemia from 21 to 14%. They decreased the pre-transfusion hemoglobins from nearly 8 grams per DL to 7.3 grams per DL, and they nearly doubled the rate of single unit transfusions. So we know that, the transfusions, do lead to higher risks and morbidity and mortality in patients. And as a result of this, of course, there was a whole lot of healthcare dollar savings. You can see they saved in activity-based costs upwards of 100 million Australian dollars. So that's all I have, and this is my references. And I thank you again for inviting me to speak.